today we're going to be doing a quick recap / revision lecture on hypertension and cardiac failure. Cool. So this will be sort of an interactive style Socrative type session. If you guys haven't used Socrative before, if you just go to Google and type in Socrative student, it'll ask you for a room name, and if you just put the room name in there, SOMA1778, at various points in this talk, we'll sort of do some multiple choice questions together, so sort of just to cover the content. Okay, awesome. So let's dive straight into it. So I thought we'd start by just doing a quick run through of control of blood pressure. And very broadly speaking, we can categorize this into two halves. So blood pressure can be controlled either in the short term, so that's sort of minutes to seconds, maybe even hours. And there's long-term control of blood pressure, days, weeks type thing. And the short-term control of blood pressure is generally a nervous thing. It's autonomic nervous control. So we're thinking parasympathetic versus sympathetic, fight or flight type situation. Whereas our long-term regulation, it's going to be less controlled by the nervous system and more by the kidneys and hormonal control. Okay, sweet. And in this diagram, we can see here we've got the sort of division of our sympathetic vasomotor nerve fibers. So on the left, we can see here that they leave the spinal cord through these thoracic spinal nerves, and then they pass into a sympathetic chain. So we can see the two sympathetic chains here on either side of the vertebral column. And then from that point, they pass through specific nerve fibers that either innervate the vasculature of the sort of internal viscera and the heart, or they are going to go peripherally and innervate sort of general vasculature, blood vessels. So that's what we've got going on the right here. And this diagram I always find really helpful. This is sort of our generic sympathetic innervation of a capillary bed. And as we can see here, the vast majority of sympathetic innervation is sort of pre and post capillary bed. So we do have some innervation of our capillaries itself, but most of it's going to be to our arterioles and our sort of venules. And the arterioles in particular are really important. We call them the resistance vessels. And what that means is that constriction of those particular vessels causes or contributes to the greatest change in total peripheral resistance. And that's really important in terms of regulating blood pressure. There's this nifty equation, mean arterial pressure or sort of arterial blood pressure equals total peripheral resistance times cardiac output. So if we can change total peripheral resistance for a given cardiac output, we can massively change our arterial blood pressure. And that's what sympathetic nervous system is doing by constricting these arterioles. By constricting the venules on the other side as well, that's also really beneficial because we call these the capacitance vessels, which just means that they have the ability to distend and sort of stretch by quite a large degree. So when your venules constrict, you shunt all your sort of blood volume in those venules back towards the heart. And that in itself can help increase blood pressure as well via the Frank-Starling mechanism. So if you guys remember, Frank-Starling mechanism is basically where we increase the preload of blood, i.e. we increase the amount of blood that we supply to the heart, and that stretches the chambers, that stretches each individual myocyte. And because of an intrinsic mechanism with it, the myocytes respond by contracting even stronger. And so that increases blood pressure in itself. So it's sort of a twofold here. We've got the sympathetic vasoconstriction of the arterioles, that's increasing our TPR, our total peripheral resistance. And then we've also got the venules and the capacitance veins acting via Starling's law, acting on the heart. And then speaking of the heart, let's not forget that we've also got direct sympathetic innervation of the heart itself. So we can think of our beta-1 receptors, and we can think of how that's sympathetic innervation of the heart's going to increase both our heart rate, so that's chronotropy, whereas it's going to also increase the contractility, the force of each individual heartbeat, so that's inotropy, and that in itself will also increase together those things will increase cardiac output. So again, if we go back to our equation, mean arterial pressure equals total peripheral resistance times cardiac output. So if we can increase our cardiac output, we can also increase our arterial blood pressure. Now, whilst talking about short-term control of blood pressure, it's also important to think about the baroreceptor reflex. And this is something more occurring sort of minute to minute, second by second. And it's quite a useful reflex to sort of get to grips with. And very simply speaking, the way it works is we have these different receptors called baroreceptors, and they mainly exist inside the walls of large systemic arteries. The sort of characteristic classical ones I'll tell you about is the one in the carotid sinus. So that's sort of in the wall of the carotid artery, just above the carotid bifurcation where it splits off into two. And then you also have one in the wall of the aortic arch. So we can see that in that diagram on the left there. And these types of receptors, they're just simply nerve endings. We call them spray type nerve endings, and they line the walls. And the reason that it's a benefit of them being in these arteries is because they are subject to the stretching and the changing of the arterial wall with blood pressure. So what happens is these receptors, these nerve endings, are constantly firing impulses to the CNS. But when, for example, there's a sudden increase in blood pressure, the artery walls will stretch. These receptors will fire at a faster rate, so they'll increase their rate of firing straight to the CNS via the medulla. The medulla can then think, okay, we've got higher blood pressure, let's bring this back down to normal for homeostasis. And so it'll activate a load of systems to bring that back down to normal. So we'll have widespread parasympathetic activation and vasodilation. We'll drop our total peripheral resistance, we'll slow down our heart rate, we'll decrease our contractility, and so we'll bring our mean arterial pressure back down to normal. Awesome. This diagram on the right here is quite useful. So we've got arterial blood pressure on the x-axis here, and on the y-axis we've got the number of impulses from the carotid sinus nerve per second. And note this is particular to the carotid sinus nerve. And we can see that generally, as we increase our arterial blood pressure, the impulses, i.e. the firing, is going to increase to a point at which we sort of levels off. But note how this only really occurs around sort of 60 millimeters mercury. That's sort of the bottom end cutoff. Anything below that, and we're not going to get any firing. And really the reason for that is probably just because we have lots of different baroreceptors and lots of different vessels that will have overlapping sort of upper and lower bounds and limits. So there will probably be other baroreceptors that are covering this lower limit here that isn't covered by the carotid sinus baroreceptor. Cool. Hopefully that's made sense. Let's jump and do some Socrative questions. So if you've forgotten, the room name is SOMA 1778. Let's have a look. So we've got the first question up here. So short-term control of arterial blood pressure is mainly, sorry, I should say mainly controlled by, and here are the options: hormonal control, nervous autonomic control, renal control, respiratory control. Well, let's just hurry this up. Okay, let's see how we did. So yeah, bang on, everyone's 100% right there. Nervous autonomic control, we've got our sympathetic and our parasympathetic. That's what we were talking about with the capillary bed, and as well as with the direct heart innervation. Great. Remember, our hormonal control and renal control is not for our short-term control, and respiratory control doesn't really have that great a control on arterial blood pressure. It has a little bit of control on heart rate in something called sinus arrhythmia, but that's sort of off the topic a little bit. Okay, so the opposite, long-term control of arterial blood pressure is mainly controlled by, what are we thinking? Okay, let's have a look. Yeah, bang on, renal and hormonal control. So we'll come to see in the next part of the talk that there's this sort of interplay between the kidneys and hormones, some of which act on the kidneys, some of which are separate, that really nicely control arterial blood pressure over a much longer period of time. Have we got a third question? Yes, we do. What are the main resistance vessels that exert the greatest control over TPR? TPR standing for total peripheral resistance. So cast your mind back to that diagram we had, where we had the capillary bed, and we had the different vessels on either side and the sympathetic innervation. Which one did we talk about having the most effect? Okay, let's see. Yeah, arterioles, great. Arterioles have the most effect, and it's actually, it can be difficult to understand that, because you think arterioles, oh, they're not that big a vessel, but it's to do with the combination both of the fact that they have such a large surface area, and also because if you think about them purely in terms of numbers, right, as we branch down from the aorta down to your sort of large systemic arteries and then down to your arterioles, we have lots of, we increase the number of branches as we go down each level. And with arterioles, they have the benefit of both being really numerous, but also having that greater surface area and that muscular layer that allows such a great change in their sort of the caliber of their lumen, and therefore in the resistance that they provide. Cool. Have we got a third question? Yeah, we got a fourth question. What's the equation linking TPR, MAP, and cardiac output? And this is quite a useful equation just to keep things in mind in terms of remembering how changing one thing can affect the other things. So total peripheral resistance, mean arterial pressure, and cardiac output. Let's see how we did. Yeah, bang on. mean arterial pressure equals total peripheral resistance times cardiac output. So remember we said that with sympathetic innervation, we're going to increase our total peripheral resistance because we're vasoconstricting our arterioles. We're also slightly going to increase our cardiac output as well because we've got direct sympathetic innervation of the heart, and that's going to increase your heart rate and your contractility, so your cardiac output is going to increase, and that total effect is going to increase your mean arterial pressure massively. There is a fifth question. Okay, cool. And then finally, where do we find baroreceptors? Is it in the heart, the brain, in several arteries, or in several veins? Yeah, bingo, in several arteries. Remember, they're in the walls of the arteries so that they can detect that stretch and that change in the arterial wall with the change in blood pressure. Great, cool. So let's carry on now. So we've had a quick talk and a quick overview of short-term control of blood pressure. Let's now have a think about intermediate to long-term control of blood pressure. I've got intermediate there just because there's a specific type of, I guess reflex is the best word for it, involving the kidneys that is more intermediate control of blood pressure than it is long-term or short-term. And what I'm getting at really here is pressure diuresis. So the thing with long-term control of blood pressure is that there's a really sort of I can't even speak properly. There's a really intimate relationship between fluid volume, i.e. the amount of volume of fluid you have in your vessels, and your blood pressure. Generally speaking, if you have a greater blood volume, you're going to have a greater blood pressure. So if, for example, you suddenly downed a gallon of water, you're going to really rapidly increase your intravascular volume. All that water is going to get absorbed, it's going to be in your vessels, and your blood pressure will increase as a result. And what will happen over the next few hours is that you'll have to go for a wee quite a few times over the next few hours. And that's because of pressure diuresis. What happens is the blood pressure increase as a result of that increased volume results in an increased blood pressure in the renal artery supplying both the kidneys. And so they'll respond by increasing their urinary excretion. And so you'll pee out more water, and that's beneficial because then that allows our blood volume to be brought back down to normal, and therefore our blood pressure to be brought back down to normal. So pressure diuresis is sort of an intermediate control of blood pressure. And with the kidneys, it's not just a diuresis, we also have a natriuresis. Natriuresis just relates to sodium excretion rather than water excretion, because the kidneys take advantage of the fact that if we kick out sodium, water will follow because of diffusion, right? The saltier something is, we create that gradient, that diffusion gradient, and an osmotic gradient for water to follow. So this graph on the left here shows as we increase our arterial pressure, our urinary volume will increase as well. So this is sort of reflecting our pressure diuresis. And on the right here, we've got our hypothalamic axis. So we start up in the brain, we've got our hypothalamus exerting a control over the pituitary, which then releases hormones that affect the pituitary. So hypothalamus up here, then pituitary down here, and the pituitary release hormones affecting on various organs. And in this case, we've got the adrenal glands sitting on top of the kidneys, which aren't shown here. And we have a negative feedback. And these multiple hormones that we're about to talk about, they each have their own different way of controlling blood pressure. And so a nice way of sort of subdividing the two different classes of hormones that control blood pressure is vasoactive and non-vasoactive. So vasoactive hormones are, simply speaking, hormones that are involved directly with modulating blood pressure caliber, blood vasculature caliber, i.e. Vasoconstricting or vasodilating. Whereas non-vasoactive substances aren't going to affect blood vessels constricting or dilating so much, they will be indirectly changing blood pressure by changing blood volume. Because remember how we said that if we increase our blood volume, we can increase our blood pressure. So the first one I want to talk about is ADH. And I think this is a bit of a mean one to talk about, actually, because we'll come to see it actually is a bit of both. It crosses both categories. It's both vasoactive and non-vasoactive. So a bit of background: ADH, antidiuretic hormone, also called vasopressin, released from the posterior pituitary gland. Remember, it's one of two hormones released from the posterior pituitary, ADH and oxytocin, and then the other 6 are from the anterior pituitary. And we probably all remember ADH in terms of regulation of osmolality or concentration of the extracellular fluid. So if we have a look at this flow chart here on the left, the hypothalamic osmoreceptors are just receptors sitting in the hypothalamus. They will detect changes in osmolality. And when the concentration of your blood goes up because you've had a really salty meal, for example, you'll become more thirsty. And so you'll take on board more water. And this is sort of a psychogenic pathway here. By taking on more water, you then dilute your blood back down to normal, but also will trigger more ADH release. And remember, ADH acts on the collecting ducts. It causes increased reabsorption of water from the collecting duct. So as a result, you urinate a smaller concentrated volume of urine. But as a result, that means that we're going to increase our blood volume and therefore increase our blood pressure. So this is one way, this is a non-vasoactive way in which ADH can increase blood pressure just by increasing blood volume because we're reabsorbing water out of the urine. Another way that ADH can impact blood pressure is through a vasoactive way. And the reason ADH is sometimes called vasopressin is because pressors are substances that cause vasoconstriction. So ADH can cause vasoconstriction, and as we remember from talking about the sympathetic nervous system, that vasoconstriction can increase our blood pressure by increasing our total peripheral resistance. And so vasopressin is often given in sort of emergency type situations where people have really low blood pressure. We give them some vasopressin so we can increase their blood pressure, and it's actually really effective. Cool. So we talked about ADH. Let's have a look at the adrenal glands now. So if you remember the adrenal glands, we can split them into the medulla and the cortex. Our adrenal medulla is mostly going to be secreting adrenaline and noradrenaline, and our cortex is going to be secreting a whole host of different other hormones. And we can subdivide the cortex into 3 different layers. You have the fasciculata, which secretes glucocorticoids like cortisol, the glomerulosa, which secretes mineralocorticoids like aldosterone, and then you have the reticularis, which is sort of secreting androgens, but that's not really relevant for today's lecture, so we'll focus more on aldosterone, cortisol, and then the medullary hormones. So if we start with the medullary hormones, adrenaline and noradrenaline, well, noradrenaline and adrenaline are very similar in their actions. We'll focus on adrenaline just because that's the hormone that's secreted. Noradrenaline is more just the neurotransmitter at sympathetic nerve terminals. So adrenaline, fight or flight, right? So it's going to be causing widespread smooth muscle contraction. It can act on alpha-1 receptors. If you can see on the left there, we've got smooth muscle contraction via acting on alpha-1 adrenoreceptors. So we cause widespread vasoconstriction, but also it can act directly on the heart. So remember, we have beta-1 receptors in the heart. We increase our heart rate. We increase the contractility. So that's another way that we can increase cardiac output and blood pressure. In terms of sort of a clinical condition that we can think about when we're talking about the adrenal medulla and adrenaline is pheochromocytoma. A bit of a mouthful. That is effectively an adrenaline secreting tumor, often found within the adrenal medulla. And as a result, individuals with this tumor give off this sort of very characteristic set of symptoms, right? They have a really high heart rate, their blood pressure's through the roof, they're really sweaty, they're really nervous, they're really on edge. And so that makes sense, right? Because they've got all this adrenaline that's being secreted out of this tumor. If we then change pace and we look at the adrenal cortex, let's start with cortisol. So cortisol is a glucocorticoid, and it's really in the name there, gluco, meaning that one of the main roles of cortisol is to raise your blood sugar, your blood glucose. Cortisol is sort of like an anti-insulin hormone. It's a bit like glucagon. They raise blood glucose. But cortisol also acts to sort of make your vascular smooth muscle much more responsive to catecholamines like adrenaline. So it sort of acts synergistically with adrenaline to increase your degree of vasoconstriction, and then again increase your blood pressure through the mechanisms we talked about earlier. On the right there, we've got two sort of individuals with Cushing's syndrome. So Cushing's syndrome. A good sort of rule to remember that a syndrome is just a term for any collections of signs or symptoms. And people with Cushing's syndromes have these different signs or symptoms. So they're often obese, they have hyperglycemia, they have a raised blood pressure, they have easy bruising. And the reason they have all these symptoms is because usually they have an overproduction of cortisol. They have very, very high cortisol levels, which causes all these symptoms. Now, interestingly, there's a very strange relationship between cortisol and aldosterone. So cortisol and aldosterone both secreted by the adrenal cortex, but they have different functions. We've already said that cortisol sort of raises our raises our blood glucose, raises our blood pressure. Aldosterone is an example of our non-vasoactive hormones. So aldosterone, remember, acts on the kidneys. It causes increased reabsorption of sodium and water. So it's sort of like an ADH type effect. We're increasing our blood volume, and that's going to increase our blood pressure. But aldosterone, it not only encourages sodium reabsorption, but it encourages potassium excretion. And so people with what's called Conn's syndrome, which is where you have too much aldosterone, they're very hypokalemic. They have low levels of potassium. Now, interestingly, people with Cushing's, so people who have really high cortisol, they also often have hypokalemia, low potassium as well. And the reason for that is if we look at the two molecules, cortisol and aldosterone, on a chemical level, structurally, they're actually really quite similar. And so what can happen is cortisol can end up acting at the aldosterone receptors and therefore have a similar aldosterone-like effect. So people end up excreting potassium, becoming hypokalemic. Now, in you and me, in normal healthy individuals, we have an enzyme called 11-beta-hydroxysteroid dehydrogenase. And this enzyme effectively is expressed by cells that have the aldosterone receptors, and that means that this enzyme will degrade any cortisol into cortisone, so it can't act on the receptors. But what happens is, if you've got Cushing syndrome, you've got so much cortisol being produced that it ends up oversaturating and overflooding this enzyme, and the enzyme can't break down all the cortisol, so eventually some cortisol ends up acting at the aldosterone receptors, which is quite interesting. Okay, cool, so I've talked enough about that. Let's now have a look at the renin-angiotensin-aldosterone system. So renin-angiotensin-aldosterone system, we've got a nice flow chart there on the left. At the bottom, we've got aldosterone, which we've just talked about. So aldosterone is going to increase our sodium reabsorption. It's going to kick out our potassium. The water will follow. So we take on board more water. We increase our blood volume. We increase our blood pressure. If we go back to the start of it, what triggers, what kicks off this system? Well, the renin-angiotensin-aldosterone system, it all starts with blood flow to the kidney. And if there's a reduced renal blood flow, this will be detected by the JGA, the juxtaglomerular apparatus, and that causes increased secretion of renin. And as we can see there, renin is going to break down angiotensinogen into angiotensin 1. Angiotensin 1 is going to be broken down by ACE, angiotensin converting enzyme, into angiotensin 2. Now, strangely enough, most of our ACE is found in our lungs. And then our angiotensin 2 can then trigger aldosterone release from the adrenal cortex. But angiotensin 2 itself has a direct effect on blood vessels. So we can see that angiotensin 2 also can vasoconstrict. So we sort of have a double action here. We've got, it's almost like with ADH, we have the vasoconstriction effect of angiotensin 2, which is increasing our total peripheral resistance, increasing our mean arterial pressure that way. But it's also going to cause increased aldosterone release, which causes increased water reabsorption, increased blood volume, increased blood pressure. So we've got both acting there. So just remember that we can divide our hormones into vasoactive and non-vasoactive. ADH sort of bucks the trend because it's a bit of both. And in this pathway here, we've got the non-vasoactive action of aldosterone and the vasoactive action of angiotensin 2. Okay, more Socrative questions to see if that all made sense. Okay, so what are the two main roles of ADH? Okay, let's have a look. Yeah, vasoconstriction and water reabsorption. So yeah, absolutely right, bang on. I'm glad no one got caught out by option A here. Diuresis, remember, is when we excrete water, we lose water. ADH is going to counteract that. It's an anti-diuretic hormone. Great. Question 7. Pheochromocytoma is where we have too much of which hormone? This should be a quick one. Can you remember the symptoms of someone who has pheochromocytoma? Okay, let's have a look, see how we did. Adrenaline, perfect, yeah. So remember, with people with pheo, have really high heart rates, really high blood pressure, they're often very sweaty, often very on edge, high blood sugars. Awesome. Question 8. Patients with Cushing's may have which of the following electrolyte disturbances? So what did we talk about with cortisol? I'll give you that as a hint. So Cushing's is where we have high cortisol. Bingo, yeah, really nice. Hypokalemia. So remember, Cushing's can have an aldosterone type effect because of that oversaturation of that enzyme 11-beta-hydroxysteroid dehydrogenase. And the last one for this section, what's the main role of angiotensin 2? And note, I've put the word main in bold there. Yeah, vasoconstriction, nice. So we could say that it also stimulates release of aldosterone release and therefore increases our blood pressure by increasing our blood volume. But the main direct action of angiotensin 2 is vasoconstriction. And actually, to be honest, here I think I've been nice and I haven't put the other option there of stimulating aldosterone release. But either way, really well done, nice. Okay, so let's crack on with the rest. Okay, so we've talked a bit about physiology, we've talked a bit about maintenance and control of blood pressure. Let's talk about when that goes wrong. So as I'm sure you guys are all pretty aware, hypertension is a sort of pathological condition where you have a high blood pressure, a sustained high blood pressure for a significant period of time. And it's really problematic. In this country and worldwide, it can damage endothelial cells. You can get arteriosclerosis as a result, which is like hardening of the arteries. And it can have so many other knock-on effects. You can get coronary artery disease. You can get an MI, so a heart attack. You can have strokes. You can go into heart failure. And yeah, it's a condition that is quite poorly controlled. Now, when we're talking about hypertension, we can really split it up into primary and secondary hypertension. Primary hypertension is effectively what we also call essential hypertension. It's really hypertension that we don't properly know what causes it. Very common amongst people of increasing age. So in the elderly population, essential hypertension is really, really common, but we haven't yet identified like a single pinpoint cause as to what's causing this hypertension. A lot of people think it's just because of increasing atherosclerosis widespread. So what's happening is they think that we think that if we have lots of atherosclerosis widespread, we're effectively increasing our total peripheral resistance globally, which is causing our mean arterial pressure to rise. There's also other thoughts that there's some genetic involvement with it. So essential hypertension, we're not entirely 100% sure on what causes it. So that's primary hypertension. Secondary hypertension is one that we're a bit more confident on, and that's what this left-hand diagram is looking at here. The most common cause of secondary hypertension is renal artery stenosis. So, and the most common cause of renal artery stenosis is atherosclerosis, as we said before, or something called fibromuscular dysplasia, which is basically a condition in which the muscular wall of the artery starts to grow to the extent that it just starts to occlude the lumen. So similar to what the fatty plaque is doing in atherosclerosis, but with fibromuscular dysplasia, it's a muscular problem rather than a fat problem. And as you can imagine, by narrowing that lumen, by making the renal artery sort of by stenosing that renal artery, what happens is we have a low and reduced perfusion pressure to the kidney. And when we have a reduced perfusion pressure to the kidney, that makes the kidney think, oh, our blood pressure is low. Let's increase our blood pressure. Let's activate RAS. So remember when we had that flow chart of the RAS system, the thing that kicked off renin release was a reduced blood volume. But the perception of that blood volume from the kidney's point of view is to do with how much blood it's receiving from the renal artery. So when we get renal artery stenosis, we get less blood flowing to the kidneys. We get increased activation of the renin-angiotensin-aldosterone system. So we get more renin release, more angiotensin II, more aldosterone. So we get an increase in our blood pressure from the mechanisms that we talked about earlier. Cool. And then I've got a picture on the right here of aortic coarctation, which is, it's to be honest, it's quite frequently talked about during med school, but it is quite a rare condition. And coarctation of the aorta is basically where we have this really massive narrowing of the descending aorta here. So we've got sort of the heart down here, aorta, ascending aorta, brachiocephalic trunk on the right, and then our left coronary, left subclavian arteries and common carotids. And then here we have our coarctation, which it narrows extremely massively. And this is another cause of secondary hypertension, because as a result of this coarctation, everything downstream is going to be at a much lower pressure. And if you can remember from your anatomy, when we go down the descending aorta, eventually we'll get to sort of this point here where we bifurcate into our renal arteries. So when the blood pressure down there is reduced, we get the same thing happening here. So really these two problems here, it's the same mechanism, but just happening at different points in the vasculature. Here we have a reduced blood flow to the kidneys at the level of the renal artery, whereas here it's much higher up, it's at the level of the descending aorta. Okay, cool. Okay, so I also want to talk about heart failure, and the reason that heart failure links in quite nicely with this topic is actually because heart failure is really commonly sort of a secondary cause of uncontrolled hypertension. So I talked about how hypertension is really, really common in this country as well as worldwide. And the problem is, if we don't control hypertension, if you're someone who is hypertensive and you don't take your medications, you don't control your diet, etc., it can progress into heart failure. And I've got this diagram of the heart here because I think the best way of thinking about heart failure is thinking about it anatomically. Now we can ignore these labels. Really what I want us to think about is where the heart is and where it's connected to. So if we look at the right side, we've got our vena cava, our SVCs up here, our IVCs down here, and this is draining venous blood from the entire body. It then gets into the right ventricle, gets squirted into the pulmonary artery, goes to the lungs to get oxygenated. Oxygenated blood comes back, pulmonary vein, left atrium, left ventricle, into the aorta to go systemically, and then we start back up again in the IVC and SVC. And the reason it's important to think about it in terms of this sort of anatomical way is because often parts of the heart will fail at different points. And what I mean by that is, for example, with someone with hypertension, they often go into left-sided or left ventricular heart failure first. And the reason for that is because hypertension effectively increases the afterload, or sort of the force, the back pressure, as it were, on the heart. So if we think of the aorta up here, hypertension and an increased sort of blood pressure will increase the back pressure in the aorta. And what that means is that the left ventricle has to work even harder to overcome that back pressure and squirt enough blood into the aorta, overcome that back pressure, and get your blood going systemically. And so the left ventricle has to work harder and harder and harder. Now, what initially happens actually is your heart's relatively smart. It'll try and adapt to this situation. So we'll get what's called left ventricular hypertrophy. Hypertrophy is increase in muscle mass when the individual cells increase in size, whereas hyperplasia is where you have an increase in cell number. So what happens is we get left ventricular hypertrophy. Your left ventricle gets even thicker than it already is. We get a thicker wall, and we get a stronger left ventricle. And initially that kind of works, that thicker left ventricle can sort of work against the high blood pressure for a period of time. But the problem is we can't keep hypertrophying our heart forever. We can only do this to a certain extent. And the extent at which that stops being effective is when that sort of left ventricular wall becomes so thick that it's not possible to perfuse all the myocytes within that left ventricle properly. So what happens is we get sort of patches of myocyte necrosis. We get bits of cell death. Remember that when the heart muscle, the myocardium, is perfused with blood, that's only happening during diastole. So if we're in a state of hypertension, the heart's going to be beating harder. We're going to get left ventricular hypertrophy, but also the heart rate will try and increase as well to sort of counteract this increased afterload. So we're going to have a reduced time to perfuse our myocardium, and we've got more myocardium to perfuse than normal because of all this hypertrophy. So we start getting myocyte necrosis. And then if we still don't sort out our hypertension problem, what happens is we move from a picture of left ventricular hypertrophy to something called left ventricular dilation. And dilation is really where you have a sort of a left ventricle that is large, it has a very large cavity, but it's really flimsy, it's really baggy, it's got a very thin wall, and it's effectively really, really terrible at doing its job. And when you're at this point, you're very worried. This is full-on heart failure. This is full-on left-sided heart failure. Anyway, I get distracted. So I was talking about the mechanics and how everything connects together. And the reason that's important is because we can sort of figure out symptoms if we know which part of the heart is failing. So if we look at the left side of the heart, if the left side of the heart started to fail, i.e. we had this problem of hypertrophy and dilatation, and now it just can't really overcome that hypertension, it can't overcome that backlog, so it can't squeeze blood from the left ventricle into the aorta, that's going to start failing. And what's going to happen is you get a backlog upstream. So if we can't clear blood in the ventricle, we're going to get a pooling of blood in the left atrium. And that's going to cause a pooling of blood in the pulmonary vasculature. So you get all this blood sitting in your pulmonary capillaries, your pulmonary veins, your pulmonary arteries, and that's going to cause pulmonary edema, which is just sort of edema, sort of fluid loss and swelling of your pulmonary vasculature. And that's why people with left-sided heart failure often have dyspnea, difficulty breathing, and shortness of breath. Now, that problem can progress even worse. So what can happen is that increased sort of stasis and vascular congestion in our pulmonary capillaries and our pulmonary arteries, that can backload onto the right side of the heart. Remember that our right side of the heart's here, we've got our pulmonary artery here, we've got increased pulmonary pressure here, which in itself is acting as an afterload against the right side of the heart. So everything that happened to the left side of the heart is now going to start happening to the right side of the heart. We've got an increased afterload, we've got an increased pressure against the right ventricle has to work against. So the right ventricle is going to hypertrophy, it's going to dilate, and then it's going to fail. And when the right side fails, we're going to get a backlog of blood into the right atrium, and then we're going to get a backlog of blood systemically into all the veins. So what happens with right-sided heart failure is people often get really swollen legs and really swollen extremities. It's particularly in the legs just because of gravity. So you get what's called pitting edema of the legs. you often also get something called ascites. Ascites is where you get sort of an abnormal buildup of fluid in your abdomen, in your peritoneal cavity. So that's why looking at it from sort of an anatomical point of view can really help differentiate between which side of the heart is failing. Now, to be honest, I'm talking about right-sided heart failure and left-sided heart failure, but in reality, it's very rare that a patient will have isolated right-sided heart failure or left-sided heart failure. And by the time you see a patient on the ward, they will probably have total heart failure, in which case they'll have a combination of both of these symptoms. They'll have the breathing problems and the difficulties from pulmonary edema, but they'll also have this pitting edema of their legs, and they may have some ascites as well. So yeah, that's sort of heart failure in a nutshell. That's how we can think about heart failure. As we talked about hypertension and heart failure, let's do a few Socrative questions before we look at management. So question 10, what is the most common cause of secondary hypertension? So remember we said that primary hypertension is this sort of essential hypertension. We're not too sure how it works. Different people think it's because of cholesterol or atherosclerosis, or even just malfunctioning of the long-term arterial blood pressure mechanisms. But what's the most common cause of secondary hypertension? Yeah, renal artery stenosis, great. Well then, actually, you guys are getting 100% on pretty much all of these, which is great. Renal artery stenosis, the most common cause of that being atherosclerosis. We reduce the blood flow reaching the kidneys panic, thinking there's a reduced blood volume, so it responds by secreting loads of renin and activating RAS. Number 11, which of these syndromes can cause hypertension? So is it Cushing's, Conn's, Fio, or all of the above? Okay, let's see what we did. Yeah, it's all of the above. So if we remember Cushing's where we've got too much cortisol. Cortisol is going to raise your blood sugar. It's also going to make your blood vessels much more responsive to adrenaline, so that you're going to vasoconstrict more effectively. Conn's, I didn't formally talk about it. I did mention it briefly. Conn syndrome, remember, is where we have too much aldosterone. So too much aldosterone, too much reabsorption of sodium and water. Your blood volume goes up, so your blood pressure goes up. Pheochromocytoma, too much adrenaline, too much widespread sympathetic activation, high blood pressure for the reasons that we've talked about. So all of the above will cause hypertension. Okay, question 12. What are features of left-sided heart failure? And do note there may be more than one correct answer here, or more than one correct option. So left-sided heart failure, try and have a think about what connects to the left side of the heart. In which way are we going to have problems? Are we going to have problems downstream or upstream? Okay, let's have a look and see how we did. Yeah, perfect. So we're going to have pulmonary edema because we're going to have that backlogging of blood into the lungs, and that's going to sit there and sort of seep out, so we're going to get fluid in the lungs. This is a bit mean, to be honest. I didn't really mention anything about the apex beat, so well done to those of you who got that. We also get a displaced apex beat. What that means is the apex beat is sort of the heartbeat that you can feel, and it's just the apex of the heart, they're contracting, and you can often feel that sort of under the sort of the left nipple of someone. And the reason it gets displaced is because, remember how we talked about how the heart will compensate, so we'll get left ventricular hypertrophy. When that fails and we go into sort of the dilation and the full-on heart failure, the heart will increase in size. So a dilated heart is often described as being really big, so we get cardiomegaly, really floppy and really thin-walled. And because the heart increases in size, the apex beat will actually shift laterally. So someone with a displaced apex beat, it won't normally be under the left nipple as you'd be expecting. It may be shifted off into sort of almost sort of under the left armpit type region. And remember, peripheral edema, we're thinking more a different kind of heart failure, which is a bit obvious what it is, but that's what the next question is. So, features of right-sided heart failure. I've already sort of given you one. Is there more than one? Okay, let's see how we did. Yeah, excellent. So we don't get pulmonary edema here because, remember, when we have a failing part of the heart, we backlog upstream, not downstream. So the right side of the heart, what's upstream of that? Well, that's our inferior vena cava, our superior vena cava. So we're going to have widespread peripheral edema or pitting edema. We get ascites as well, and we get a raised JVP, and that is a bit mean of me because I didn't actually fully explain what a JVP was. So a JVP, jugular venous pulse, is it's a vein in the neck. You can often see it in people who have right-sided heart failure as being very prominent. And the reason it's raised in someone who has right-sided heart failure is because the JVP is effectively communicating with the right side of the heart. It connects to the supraclavicular vein, I think, and then into the superior vena cava. So when you have right-sided heart failure, everything backlogs. So you get venous blood backlogging into the JVP. So it's much more distended and it's much wider and more noticeable. And you can see it between the two heads of the sternocleidomastoid. Okay, excellent. Is that it for this part? Yes, that is. Okay, so for the last 15 or so minutes, I want to talk about management. And the problem is there are loads of different drugs that can manage hypertension and heart failure. But the good thing is that there's quite a lot of overlap, and that a lot of the drugs that we use to treat hypertension are actually similar, or if not the same, as the drugs that we use for heart failure. And that is sort of because of the reason that, you know, hypertension can actually knock on and cause heart failure, but also because they're both caused by problems with blood pressure and blood volume. So let's have a talk about the hypertensive drugs, the antihypertensives. So I'm going to group this into three main groups. We've got our vasodilators, our diuretics, and our sort of cardio-inhibitory drugs. So vasodilators, we'd obviously, if we're in a state of hypertension, too high a blood pressure, we want to vasodilate. We want to drop our total peripheral resistance, and we want to drop our mean arterial pressure, if we remember that equation at the start. So the main vasodilators we're going to use are alpha-1 adrenoreceptor antagonists. If you remember the alpha-1 receptor, when adrenaline binds the alpha-1 receptor, we get vasoconstriction. So an antagonist can block that effect and dilate it. And a common one that we use is prazosin. Now, with any drugs that are going to be inhibiting our sympathetic nervous system, whether it's our alpha-1 receptor antagonist or our beta-1 receptor antagonist, a really common side effect is postural hypotension. Sometimes called orthostatic hypotension. And what that is effectively people, if they're sat down at their desk, for example, and they suddenly stand up, their blood pressure will drop quite a bit. They'll suddenly feel quite lightheaded. And if it's really bad, they may pass out. And the reason for that is because we've sort of overcorrected so much. We've decreased their blood pressure, but as a result, we've decreased to the point where they can't control their blood pressure rapidly when changing their position. So as a result, they can be hypotensive when they change their posture, hence the name. So that's a common side effect of that. Another group of drugs we use are ACE inhibitors. So if we remember the RAS pathway, that flow diagram we had earlier, ACE is that enzyme that converts angiotensin 1 to angiotensin 2. An example of this drug, by the way, is ramipril. Actually, we've got a list here. So the prils, if you remember pril, are your ACE inhibitors, ramipril, captopril, etc., etc. And so if we block ACE, we block the conversion of angiotensin 1 to angiotensin 2. And that's actually really effective because remember, that's going to stop two things. We get less angiotensin 2, which therefore means less angiotensin 2 mediated vasoconstriction and therefore angiotensin 2 mediated, increase in blood pressure. But we also are going to reduce the amount of aldosterone because angiotensin 2 activates aldosterone release. So we get less aldosterone release, less increase in blood volume and blood pressure. So it's sort of 2 for the price of 1, which is really effective. And actually, ACE inhibitors are really commonly given to people who have diabetic related hypertension. Okay, a common side effect of ACE inhibitors, however, is weirdly enough a dry cough. And the reason for that is because of a substance called bradykinin. ACE, the enzyme, doesn't just break down angiotensin 1 to angiotensin 2, it breaks down a lot of other things as well, one of them being bradykinin. So if we inhibit ACE, we get an accumulation of bradykinin, particularly in the lungs, and that can cause this sort of characteristic dry cough symptom. Not a terrible symptom, but just one to be aware of. And so what we can do is we can use a different drug that acts on the RAS system, but slightly lower down. And these are called ARBs, A-R-B, or angiotensin 2 receptor blockers. And they do exactly what they say on the tin. So these drugs will block the receptors of angiotensin 2. They'll prevent angiotensin 2 causing that vasoconstriction. They'll prevent angiotensin 2 activating and releasing aldosterone, but they don't do it at the level of ACE. They do it one level down at the level of the receptor. So we no longer have this problem with the dry cough because we don't get that accumulation of bradykinin. So that's quite ideal. We can also talk about ion channel blockers, particularly calcium channel blockers and potassium channel blockers. So calcium channel blockers, the classic one being something like nifedipine, they really effectively just act at calcium channels within the vascular smooth muscle cells, which prevents calcium channel influx, and that's going to inhibit that vascular smooth muscle contraction through the excitation contraction pathway that we all learned in first year. So that's going to prevent or reduce vasoconstriction, so we get more vasodilation, and that sorts out the hypertension problem. We can also use something called potassium channel activators like minoxidil, and this sort of works in a similar way, but potassium channel activators. So they activate potassium channels. If we activate potassium channels, we're going to hyperpolarize the cell membrane because we've got lots of potassium inside. It's all going to flood out. We're going to hyperpolarize the cell membrane, which means that they are more difficult to activate, more difficult for contraction to occur. So again, we get vasodilation. Furthermore, by hyperpolarizing the cell membrane, we make it harder to activate calcium channels, which are needed for that influx of calcium and contraction. Okay, awesome. And then finally, let's just quickly talk about diuretics. So diuretics are sort of attacking hypertension from, rather than a vascular point of view, from a blood volume point of view. So we can use thiazide diuretics, loop diuretics, or potassium-sparing diuretics. And they all act at different points of the nephron or of the kidney. So thiazide diuretics, an example being something like bendroflumethiazide, they act by inhibiting the sodium chloride co-transporter in the distal convoluted tubule. So you get less reabsorption of sodium, less reabsorption of water. You don't get that increase in blood volume, and therefore you don't get an increase in blood pressure. Loop diuretics, similarly, similar concept, but just working on a different transporter in a different part of the nephron. So they work in the loop of Henle, the ascending limb of the loop of Henle, and they inhibit the sodium potassium chloride carrier. And again, they're inhibiting they're inhibiting your reabsorption of sodium. They are encouraging sodium excretion or natriuresis, and water will follow. And so we pee more, and therefore we drop our blood volume and our blood pressure. Aldosterone antagonists is the third group, and they're the most interesting, personally, I think. That's just because they are diuretics, but they're diuretics by inhibiting aldosterone. So an example of this would be something like spironolactone. And what they do is they will compete with aldosterone for its receptor. So they'll inhibit aldosterone from encouraging sodium reabsorption, and therefore we get less water reabsorption, same as before. But the benefit of these is that, remember, with aldosterone, we're going to be kicking off a load of potassium. We're going to be hypokalemic. So we often give spironolactone for patients who either were worried about hypokalemia or generally were worried about their potassium levels just being too low. But of course, sort of like what we talked about with the postural hypotension with the sympathetic drugs, you've got to be careful not to go too far the other way. So people who are only on potassium-sparing diuretics, you have to make sure that they don't become hyperkalemic, because that's also a big problem. So that's sort of a crash through the different drugs for hypertension. Regarding, oh, sorry, actually, I forgot the cardioinhibitory drugs. That's my bad. So the cardioinhibitory drugs states what it says on the tin. So they are going to be inhibiting the heart. So we're going to be inhibiting particularly heart rate and blood pressure. And so that's going to be acting from a heart point of view for reducing that cardiac output. If we remember that equation again, we're dropping our cardiac output, we're dropping our mean arterial pressure. So here we're thinking beta blockers and beta-1 antagonists. And remember, beta-1 antagonists are going to be mostly acting on the heart, although they can act on some vasculature. So we reduce our blood pressure, we reduce via reducing our heart rate and contractility, and we're thinking of things like propranolols. The lols generally are your beta blockers, but calcium channel blockers as well. But just note, the calcium channel blockers that we use to target the heart are different to the ones that we use to target the vasculature, because there's a very slight subtlety in the calcium channels involved. So I said for the vasculature, we use something like nifedipine, whereas for the heart, we use something like verapamil. And that's important to be aware of in case you have a patient who one is contraindicated for and the other one isn't, or for some reason like that. Okay, cool. So that's the drugs for hypertension sorted. Let's just quickly talk about the drugs for heart failure. I've got this diagram up on the board. Before we talk about that, I just want to quickly mention the fact that, as I said earlier, uncontrolled hypertension can progress to heart failure. And lots of the drugs that we use for hypertension, we can still use for heart failure, and they can actually be very effective. And actually, some of them they can sort of do two for the price of one and help us out twofold. And if we think of diuretics, the reason that they're really beneficial is because they drop our blood volume and therefore our blood pressure. But also, by dropping our blood volume, they can really help with the symptoms of heart failure, for example, our pulmonary edema or our peripheral edema. In those widely edematous states, we want to offload fluids so that we reduce the level of swelling. And so diuretics can be really helpful there. If we look at this diagram here, it looks a bit chaotic, but it's actually quite important. In heart failure, physiologically, the body sort of panics, and as a result, we get inappropriate activation of these two pathways here. We inappropriately activate the RAS system, and we inappropriately activate the sympathetic nervous system. So let's talk about why that happens. So the reason that we activate RAS is because, remember that with heart failure, we're getting pulmonary edema, we're getting peripheral edema. What that means is that we're losing fluid from the vasculature, it's seeping out into the interstitium, and so we get a drop in our intravascular volume. So as a result, in the kidney's perspective, we have reduced blood volume. Even though none of that volume has left the body, it's now been moved from inside the blood vessels to sort of the interstitium, and that's where the swelling is. But in the eyes of the kidney, our intravascular volume has dropped, and that needs to be sorted out. So what happens is kidneys activate RAS. But what does RAS do? Well, RAS is going to cause increased aldosterone activation, increased water reabsorption, and that's just going to make the edema much worse. Right? It's going to make the edema worse, and it's also going to make the hypertension that was causing the heart failure even worse. So that's why it's inappropriately activated. If we talk about sympathetic nervous system, we get inappropriate activation of that, and that's because when the heart's failing, the sympathetic nervous system thinks, right, if I activate, I can cause the heart to pump harder, and maybe that will help some of the heart overcome this this hypertensive afterload, and maybe it'll help some of that, some of the heart increase contractility and, eject some of the blood effectively. But the problem with the sympathetic nervous system activation is that that comes with the price of increasing oxygen demand of the heart. And so we said earlier about how when the heart is failing, it's in a sort of section of myocardial ischemia. We've got lots of cell death. We've got lots of oxygen demand. The heart is generally really ineffective, and so by activating the sympathetic nervous system, all that's doing is making myocardial ischemia worse, and it's making an ineffective heart even more ineffective because it's making it even more demanding of oxygen. So how can we use drugs to sort of offset these two pathways? And that's what the green arrows are showing here. So if we look at RAS, well, we can use ACE inhibitors and we can use ARBs. They act both directly on the RAS, as well as aldosterone antagonists like spironolactone. We can also use diuretics to offload the fluid, and we sort of mentioned that a bit earlier. But really interestingly, beta blockers actually help attack both of these problems. Obviously, beta blockers are going to help prevent the problem with the sympathetic nervous system. They're going to activate the action of adrenaline at the beta-1 receptor. So we're going to reduce our heart rate, reduce our contractility, reduce that sort of myocardial oxygen demand. But beta blockers also prevent sympathetic stimulation of RAS, and actually there is some sympathetic stimulation of the kidneys, which causes increased renin release. And so beta blockers can help block that increased renin release from the sympathetic stimulation of the kidney, and so they can sort of effectively antagonize both of these inappropriate pathways. And so that's why beta blockers are actually really, really effective. Now I talked about briefly about how the problem of the failing heart is that's really ineffective. But one thing we can do is we can increase its contractility without increasing the myocardial oxygen demand. And that's by taking advantage of the Frank-Starling mechanism that we talked about earlier. If we can vasodilate, and this is where we use things like the GTN spray, so people who have angina, if they take a puff of the GTN spray, this can help with that, because by vasodilating, they'll increase the preload being received in the heart, increasing the stretch of the heart, and that process of Frank-Starling doesn't actually occur at the cost of needing more energy. This is sort of an intrinsic mechanism that's relying solely on the stretch of myocytes. So we can use drugs like GTN, like isosorbide mononitrate, like cardiac glycosides, which can all help increase our preload, increase the effect of Frank-Starling, increase cardiac output without demanding more oxygen from the heart, and therefore making the states of heart failure way worse. So that's another group of drugs rather that we could use. Okay, I think we've got a few more questions, just 3 or 4 more questions, and then we are done for the evenings and you guys can carry on with your lives. So, question 14, prazosin is what kind of drug? Okay, so yeah, it's an alpha blocker, and to be specific, it's an alpha-1 blocker. Okay, it's an alpha-1 antagonist. It's going to help offset that vasoconstriction, and we can vasodilate. Great. Side effect of ACE inhibitors, but not ARBs, is what? And this is where ARBs can provide some potentially symptomatic benefit that ACE inhibitors cause a problem of. Yeah, dry coughs. Remember, we get that dry cough because we get that accumulation of bradykinin in the lungs. Which 2 systems are inappropriately activated in heart failure? Yeah, perfect. So we get inappropriate activation of the sympathetic nervous system and of the renin-angiotensin-aldosterone system, just like that flow chart showed us. And the final question, where do thiazides act? And I should have been more specific, but the options make it pretty clear. Where in the nephron do they act? Yeah, perfect. They act on the distal convoluted tubule. Remember, they're acting on that sodium chloride co-transporter. Ascending limb of loop of Henle is where our loop diuretics, so it sort of helps with the name there. Loop diuretics act on the ascending limb of loop of Henle, like furosemide, whereas bendroflumethiazide, that's going to be acting on our DCT. Okay, awesome. I think, yeah, that's everything I had to talk to you about this evening. I hope that was of some use and somewhat helpful. Yeah, if you guys have any questions, let me know. I'll do my best to answer if I know. And my email address is there if you want to send me an email, you know, if you remember something you want to ask me about. But that's all for today. So thanks for listening, and thanks for getting involved with the Socrative questions.